Okay, so well, welcome to Infectious Diseases and our guys. So Bruce has just put a symposium together, discussion together around TB after the last discussion where we do lots of things without having good reasons for them. So I was asked really just to talk a little bit about our approach to TB and just talk about how we use drugs and why, which is going to be very anecdotal rather than based on anything. But I thought I'd just give a little bit of a sort of intro to TB. So a bit of a lag. Okay. So this is a recent case that I had. I think it demonstrates quite a lot of interesting things around tuberculosis. So this is a 50-year-old female internationally competitive CrossFit athlete. And she had a year or so of interscapular pain, which she attributed to a training injury. And she went through a variety of sports physicians, biokinetics, general practitioners, and a variety of treatments. And then sort of treated this as this niggling muscle injury. And then developed 4 months of sleep disruption. And she went to she lived in Port Elizabeth, and she went to a local GP, sent on to the neurosurgeon, and he did the right things. He did a full blood count, ESR, CRP, and the ESR was 14, CRP is 1, but it persisted, so he did an MRI scan, and they saw those features on the MRI, which to a spine surgeon and a radiologist is very indicative of a discitis. And so in the context of this patient, they were thinking of pyogenic discitis, although there is some paravertebral fluid there, and he arranged a CT-guided biopsy. And they did a percutaneous biopsy, and they got a scanty Staph aureus on one culture. Everything else was negative. They sent off a TB PCR, and they got nothing else. So they treated this patient with 6 weeks of cloxacillin based on the diagnosis of staph osteomyelitis. She didn't get any better. And they repeated the MRI scan. There was some progression. You can see on the contrast view on the right, quite impressive, the uptake of contrast from the neovascularization. So they flew down, and I did a costrotransectomy cystectomy and open biopsy to get more tissue, and we diagnosed Mycobacterium TB on initially the PCR and subsequently on the culture, and we commenced RIFA-4. And she was sensitive according to the tests to all our first-line agents. So this is the lady. That's what she does. She's doing at this time. So she's quite, you can see, very fit lady. And she sent me this video to say she's doing so well after 7 months of medical treatment. But she's German, actually. And I don't know, those of you that treat German patients, they're very intense and they want follow-up MRIs and so on. So you've got a follow-up MRI. And now we had a patient that's doing headstands with the MRIs deteriorated on full dose RIFA-4. And so I chatted to Greg Simmons about this, who's helping with her, and he did rifampicin levels, and he found she had very low rifampicin levels despite adequate RIFA-4. And he made an assessment of her she being a rapid rifampicin metabolizer, and she was basically getting ineffective levels, and so he ramped up the rifampicin component of the treatment. And unfortunately, she didn't get better, and we had to go do an operation where we opened up and we actually debrided the tissue, and she subsequently got back to full sport. So it was just interesting, this case, because it's not the picture of the TB patient that we carry in our minds. And I've had a few in the years come from various levels of social strata you don't expect it in, and they often don't get diagnosed because we have our view of who gets TB, but it can affect anybody. Diagnosis can be extremely elusive. And in our country, we have to maintain a very high index of suspicion. And, so we create all these numbers about the incidence of TB, and we published this in 2019, I think it was. We worked out on a lot of assumptions on the sort of how many people are in Cape Town and so on, who really knows. That TB of the spine is about 1.6 per 100,000 population, so that we sort of worked out. And it's quite interesting. It's something we're just submitting now for publication. We took the last 100 CT-guided biopsies that were done in this hospital for suspected a lesion, and 77% came back as TB. So the thing is, if you just see a lesion, you call it TB, you're going to be right 80% of the time, which is about as sensitive as some of the tests the world has to offer. So, and it's a bit of a problem for us because it's so risky. We divide the work around lesions on the spine between neurosurgery, tumors, and infection is orthopedics. And of course, they say TB every time, and they're going to be right 80% of the time. So anyway, so it's just interesting to remember that where we work affects really how things work. And we obviously, we did, when PCRs came out, and the gene expert specifically, we had surprisingly quite a high sensitivity and specificity compared to many of the other published papers. So many papers will say in the sort of low 80s to mid 80% sensitivity and specificity. Well, this is what we found, or Michael Held, with his PhD on this, found those. I think one of the reasons is that our technique is they spin the sample that they give them down, they concentrate it where, and I think that increases your yield. And the other things, we use tissue largely. The only one of the few false negatives we had was pus, and I was told that there is an enzyme in the pus that may interfere with the working of the gene expert. So anyway, so in this hospital, we have quite a, with the methods we use, we have quite a high yield on gene expert in TB of the spine, even being mostly bacterial. But I just wanted to remind people, because a lot of emphasis gets placed on histological diagnosis and the presence of necrotizing granuloma. And again, because you're going to be right 80% of the time in TB. So this was actually a corridor consult, so typical, mothers and an orthopedic surgeon, fathers and an anesthetist, child's crying at night and from pain, can't sleep. And then the mom noticed the one shoulder's a little bit high, took an x-ray, saw this mild scoliosis. They gave me a call because I do quite a bit of scoliosis. And I just said, look, if you go to my Red Cross clinic, a child that's not sleeping at night crying, you're going to get a bone scan, you're going to get a full blood count, do your side. I mean, rather do things properly than this, because she was saying she'll come back in 6 months to see what's got worse. Well, she had a scoliosis operation. And in fact, the bone scan was hot, the ESR was 43, full blood count was normal, and they went on to do some further imaging. And this is when the DICOM started being sent around the world. We send it to every doctor in the world. So they thought this might be a Ewing sarcoma, actually. Not sure why, but I think people were thinking the worst. And we did a biopsy. I said, slow down, let's do a biopsy before we start flying the child away. And she was negative for culture sensitivity, negative for TB PCR. And the problem was there was necrotizing granuloma. And there was neutrophilia, which is obviously unusual for TB. But the whole idea was, is this TB? So then we waited for the TB culture. It was negative. We repeated it. And then I spoke to Dr. Spinal, one of the private pathologists, and he just said, neutrophilia, that's an interesting thing. Says you can get it with cat scratch disease. Does the patient have any cats? I phoned the patient and I said, do you have cats? You've got 7 cats. So then we did so I said, what does that mean? So it's not cat scratch disease. So I went and Googled 7 very old articles on cat scratch disease, and it does exist, obviously. And it's this little bug, which you can't culture because it's intracellular, apparently. And we made the diagnosis on serology and subsequent PCR. So we just have to remind ourselves, even though you're going to be right 80% of the time we say TB, just because you've got histology with necrotizing granuloma, it does not have to be TB. And so this was very close to home, this patient. So when do we operate? So we operate for a diagnosis, and it's becoming less often, to evacuate a large abscess and for neurological compromise and deformity. Now, typically in the past, we had a lot of resistance from our radiologists to do percutaneous biopsies, and the yield is very, very low. They tend to use very tiny needles. We had Zach, for briefly, he's gone to private practice, and he was using a large bore, and we definitely had a far better yield on our histology, and it became very good service. Instead of our patients lying in hospital, waiting for an hour and a half in theatre, because that's what a biopsy takes. And I know it frustrates the hell out of you guys. You can't just do the biopsy. But for us, it's like equivalent to an operation. By the time you take the patient here, put them to sleep, position them, the actual clinic cut it, put the needle in is quick, but it still takes an hour and a half of time, and it's a massive resource for us. And so we're reluctant to do it if we can avoid it. And when we had Zach here, the CT guided biopsy system was working very well. It seems to have fallen off a little bit again, and hopefully we can get that moving. But this is an example of the patient was sent to me as TB at that stage, and maybe you guys know it, but I didn't know this genetic condition of chronic granulomatous disease associated with certain bugs. But this was sent to me by a rheumatologist, and this must be TB. Why don't you please do a angiocorpectomy, remove that C7 and reconstruct? And I said, no, let's do a biopsy, and it came back at aspergillosis, and if you understand the underlying condition, you will expect that now. And as you can see, 6 weeks of a voriconazole totally resolved. So the patient didn't need, in fact, if it was a CT guide, it would have had no procedure. This is a 13-year-old child. You can see the very large psoas abscess. These children usually children come in with severely flexed hips, unable to walk, can be misdiagnosed as a hip septic arthritis. And to my mind, the penetration of that abscess is just going to take so long to resolve. It will, but it takes so long. And we do a simple operation, release that pus, get all the tissue for results, and within a day, the child's walking. So that'd be an idea where we would operate simple operation. Neurological deficits, we operate generally, except if anybody's deteriorating dramatically neurologically, we intervene. Those that come in, like we get many patients referred to us as Frankel Bs and Cs, off their feet for some time. We know from the very old Hong Kong studies that medical care is as good as surgical care in terms of neurological outcome. Our experience, and it's not well published, but it's general surgical father to son experience, is that they recover quicker if they're going to recover with surgical decompression, especially if there's bony compression, it's not going to resolve medically, so I would remove it. But if there's pus, they seem to get better quicker. And our pressure on beds to get people out of here, and the often poor nursing care that leads to the complications of recumbency with paralysis. So we tend to operate with neurological deficit if the patient is otherwise capable of undergoing the procedure. And then lastly is deformity. So there is evidence to predict deformity based on the amount of vertebrae destroyed. So if you treat somebody non-operatively, your 5-year kyphosis is related to the amount of destruction in terms of the bodies of vertebrae. And the question is how much kyphosis is tolerable. If you look at it, we're all trying to avoid late onset paraplegia, which is not due to the actually acute disease, but kyphosis with an internal nubbin and the spinal cord rubbing on that and causing late onset gliosis and irreversible paraplegia, as opposed to the reversible one that you get when it's acute disease. You tend to have to get pretty big curves. If you look at the studies that looked at the paraplegia like that, they tend to be around 100-degree kyphosis. That's quite big. When I worked in Europe, in the UK, they would often operate for a 30-degree kyphosis. I think, we work on about 60. More than 60 is probably unacceptable. But, because it's all risk-benefit. And then, how do we do it? We just have to remember where we're working and who's doing it. I just want to show a video clip so the non-surgeons get an idea of why we use the drugs we use as a small little defense. But I mean, this is a typical thing of cervical disease. You can see there, a very simple operation by our standards, do through the neck, remove the bone, put some ileocrestin and plate it, and the patient's happy forever. So this would be our more typical thoracic. We always say it's more common in thoracic, but if you do mass, it's 12 thoracic versus 5 lumbar versus 7 cervical, so it's more likely it's going to be thoracic just on numbers. But I mean, that'd be typical of TB, and just for the experienced X-ray people, when you see this, always look at the posterior elements, and immediately you can identify there's 2 vertebral bodies there. It's not just a wedged single vertebra. But this is a video I want to show Mark. So the main thing here is a video thoracotomy just too. But what I want to show you is what the abscess looks like, because one of the reasons we think we require drugs for longer time and multiple drugs is that the penetration of the abscess is not as good as as in the lung, and I mean, lungs well vascularized and so on. So when we do this sort of work, we open the chest, and you see this is the abscess here, and they ought to be over here, and we just expose it, and I'm going to incise it so you can just see it. Zoom just slows it down a little bit. So there's the easy pus, and we always take a sample of the pus, we send that off for Robin's PhD. And then this is the case here. This is what caseation looks like to the eye. And you see how not avascular it is. It doesn't really bleed. And you just wonder how well those drugs are getting into it anyway. Then we do the rest of the orthopedic bits. So that's really, I just wanted to give you an idea of what we faced with in there, and to give you. And then sometimes we get more complicated things, like a 4-year-old child with multiple vertebral involvement, myelopathy from compression. And here we may do traction for a while. We'd operate. We may use a halo. Sometimes we put screws, small screws, and so on. So it can get a bit more complex. And more now we do the surgery all from behind, where I'm not going to go through each video, but we expose the cord from behind. We sacrifice some of the nerves and reconstruct. We do a circumferential. We believe we want to get all that pressure off the spinal cord, debulk the caseous tissue as much as possible, and then reconstruct with the tools that we have at our disposal. Then we can get that sort of thing. So just this picture, sorry, this is lag. So using that circumferential decompression, you can see we get quite good neurological recovery. So of our Frankel C, so that would be sensation, tact, useless motor. All our patients became ambulatory. 6 normal, 3 had slight motor weakness. Of those that could walk, we had 1 catastrophic child came back from home, instrumentation failed and became paralyzed, but we generally maintain it. And all those that were normal stayed normal using the circumferential technique. And sort of one of my papers many years ago, we just looked at outcome of all comers, all the adults, in terms of what we did. And then the blue shows preoperative and the red is post in terms of the Frankel scoring. And I remember these papers used to get rejected by the international literature because they would tell us that Frankel A's, in other words, no motor, no sensation, do not recover, because people are used to trauma where there's much more energy dissipation during these injuries and they're very unlikely to recover. But you can see the vast majority of our Frankel A's do recover. You can see the shift of the red towards full neurological function. So that's what makes TB a very pleasant condition to treat, because you get good outcomes. So problems are your quality, your patients, your host status, which is often a difficult thing. And if you look at the softer items like emotional and general health status, energy levels, pain, so on, these lines show how they improve. As you get to the periphery, it's better, and each one's a different number of weeks. So you can just see the physical takes quite long to get there, whereas actually the emotional side of things, they're quite happy they get treated, so they score quicker. Just to show the orthopedic surgeons the feelings too. So then there's the crutch slide over here. So what duration? So I think we were hammered a little bit last time, like, why do we use 9 months? Now, I wrote some papers years ago on medical management, and I researched what other spine surgeons were doing. And I mean, in India, they're still using 10 months. UKZN, they're still using 18 months. And there's no strong reason for this. We all used to use 18 months. And in the early 2000s, when HIV was new to us, we differentiate 18 months for HIV positive and 9 for non. We've settled on 9. We used to be 12. When I came through as a registrar, we were 12 months here. Why I think we changed is in those days the daily observed therapy was 5 days on, 2 days off, because the clinics were shut over the weekend. Then we got to a continuous situation. So we felt we could shorten. It was a little bit shorten, let's see. And we monitor our patients. So the way we manage these patients, we do whatever we do, and then we see them at 3 months, 6 months, 9 months. So we can follow them clinically. Are they gaining weight? Are they feeling energy? Their levels getting better? Is their x-rays looking better? And their neurology incoming? And if that's all happening, we'll stop at 9 months. If there's any concern, we will go on for 12. Now, it's purely, we wait to be enlightened, but that's been our approach. Why do we go long? My concern is about recurrence. Yes, we might get really control right in the beginning, but we've been taught that there's an intracellular, slow, metabolic mycobacterium sitting in that macrophage. We kill the easy ones, but we've got these little lurkers. And our concern is the lurkers come back. They're in areas that we may not get good penetration of the antibiotics. We know on post-op MRIs or even follow-up MRIs, we get these persistent collection of fluids, which we're told are sterile, but how sterile are they? So that would be the reason that we're still using 9. I know the province came out some years ago and they just said all extrapulmonary TB is 6-month therapy, 2 months of 4 drugs and 4 months of continuation phase. Anecdotally, the patients that have come back with recurrent disease or persistent disease have been the ones that get dropped to the 2 drugs. Now, look, you see what you look for, don't you? But, that's been our case. And we, as Mauritius, when I was chatting to him about it, we're never quite sure how many patients are dropped to 2 drugs, because they may be successfully treated on the 2 drugs. But the ones that come back to us and we have problems with, which often have comorbidities and other diseases, associated diseases, HIV and so on, because 50% of our patients have HIV in this group. Seem to be the ones that have been dropped to Rifina. So that's our reluctance to change. So our current protocol is Rif for 9 months, with a possible extension for 3. But I'm open to hear what you guys have to say. Thanks very much.
Afternoon, everyone. For those that don't know me, I'm Tari. I'm one of the infectious disease fellows at UCT. And today I'm going to be taking you basically through the evidence for the treatment regimen as well as the duration of treatment for spinal TB. Okay, so let's go through. Okay, so we're going to go through bactericidal versus sterilization TB. I just want to give you some definitions so you can understand the basis towards the talk. So bactericidal is basically the rapid clearance of these extracellular metabolically active bacteria. And there's something called EBA, so it's early bactericidal activity, and essentially it's a fall in the log of the colony forming units of MTB per mil per day for the first 2 days of treatment. Okay, and then sterilization is essentially targeting the metabolically dormant or the semi-dormant bacilli, as well as those other bacilli that may be in sanctuary sites. And one can think of intracellular bacilli being part of this metabolically dormant population. Okay, and then this is just a table basically showing how the drugs work. I think the core towards understanding what regimen to give is to understand what each drug does on an individual level. So as I said, early bactericidal, first 2 days, and as you can see, rifampicin got pretty good, intermediate, but very good for sterilization, actually the best one. INH, and you'll see a little bit later, actually is the highest for EDA and intermediate effect on sterilization. PZA, pyrazinamide, not the greatest there, but for sterilization, it's a good drug. And then ethambutol is intermediate to high, but with regards to sterilization, not a great drug. Okay, and then this is basically just showing what I've explained. This is EDA with regards to the first 2 days of therapy, and as you can see over there, isoniazid has the biggest effect on the bacterial populations, followed by PAS and ethambutol. PAS, we don't really use so much nowadays. There is data to support that it's not as good as the other drugs, and then, I mean, it does have quite a side effect profile as well, including diarrhea. I've only probably prescribed it once or twice in like 2 years, yeah. Not a commonly used drug. We usually use it for our drug-resistant TB populations. And then rifampicin, great drug. Streptomycin, not bad, but we've moved away from the aminoglycosides, a lot of ototoxicity, and as you guys all know, nephrotoxicity, so not a drug we go to. And then there's pyrazinamide. This other drug here, we don't even bother with. I haven't. This is the first time I ever learned about this drug. I was like, no. And then, so let's look at the bactericidal killing. INH isoniazid, as I said, first 2 days really drops your load. Rifampicin killing in the first 2 to 7 days, and then PZA is basically 14 to 28 days. And I put this graph over here to show the log colony forming units over there and then the days of treatment. And as you can see, this is a very old study, 1956. And the HZ regimen, so that's isoniazid and PZA, dropped your bacterial bacilli load very significantly, up to 60 days, whereas SPH, that's streptomycin, PAS, and INH, you can see it's a lot slower. So hence we don't use streptomycin or PAS as much. Okay, so I'm sorry to bore you, but it does make a difference about understanding why PZA is given for its duration of treatment. So essentially, what does PZA do? It as we alluded to earlier, it goes for the metabolically active TB bacilli and looks at the extracellular matrix bacilli. So that's basically it's the bacteria that are sitting in the cavity. So if you can think of pulmonary TB, you can imagine the cavity. The bacilli mainly sit in that area over there, but has got not much activity against intracellular bacilli, but that is a little bit of a controversial point. Some people say, no, it does, and some will say, no, it doesn't. And the way that PZA works is that there's your PZA, it's actually the prodrug, so it needs to diffuse across into the MTB, and then it's changed into pyrazonic acid, and that has to change. That reaction happens because of acid production that happens within the bacteria, and the metabolically active bacteria are the ones that are going to produce lactic acid, and then the acid then changes to pyrazonic acid, and that's how basically it's able to kill the bacterium. And importantly, it's also very important that you note that it should be combined with rifampicin for its effects to be even greater. Okay, and then once again, a very old study, but this is short course chemotherapy done in Hong Kong. And I specifically tried to show PZA and why it's used for 2 months rather than 4 months rather than 6 months. And as you can see here, what they've done in this regimen is streptomycin, isoniazid, rifampicin, and PZA. This is the three, illustrates 3 times a week. And they gave PZA for 2 months, then 4 months, then 6 months. And they gave for 6 months the regimen in total. And the relapse rate at 2 years, as you can see, is pretty similar between the different regimens. So in other words, you can say to yourself, well, PZA after 2 months, yeah, probably not that effective. And then what is the clinical implication? So back in the day, they would probably, well, back in the day when we didn't have TB treatment, there was nothing. Go to the sanatorium and breathe in some fresh air, or go to the top of the mountain. But now PZA is come onto the, well, is now one of the great drugs that we have in TB, and it's basically our regimen has gone from 12 months to 9 months, and now we're sitting at 6 months. But as I already said before, it must preferably be combined with rifampicin. And also there's data to show that the relapse rates when PZA is added into the regimens is much less. So for example, when we have our DILIs, our drug-induced liver injury patients, if the PZA is 12, we actually extend our treatment duration from normal 6 months to a 9 months regimen because of the fact that the PZA is lost. Okay, so let's look at ethambutol. Same slide that I showed you earlier, just with ethambutol. As I said, EVA is intermediate to high, and sterilization is not great. So then you're going to say, hang on, why are we even bothering with this drug if hasn't got much utility with regards to sterilization? And it is actually a pretty good drug to still give, because as you all know, in HIV, we always punt. Patient must get triple therapy. Well, not in every case, but in most cases, we'll say patients must be on 3 ARVs, and that's to make sure that you decrease the likelihood of developing resistance. So what I'm saying is, for example, you might have this MTV bacillus over here, which is rifampicin resistant, but is PZA sensitive. So you can imagine if you've got PZA, it will take care of that population. So it decreases your risk of developing resistance when you've got a lot of drugs on board. And obviously we know there's an increased success in patients that have been that get ethambutol for sensitive TB. And then you might say, but hang on, so why aren't we just continuing it for 6 months then, if we still see that there's a utility towards giving patients the drug in the four drugs in the first 2 months? Well, the reason being is that by the end of 2 months, your ciliary load is exceptionally small, to the extent that you could just still go on to your rifampicin and isoniazid to take care of those other intracellular bacteria that you might not get to. And also by that stage, your resistant mutants are probably not there anymore. Well, at least you hope that is the case. And this was a really nice article that Prof. Osserman sent me, and if anyone has the time, it's 51 pages, but sure, it's a really nice read. I haven't read all of it, I can tell you that much, but it really goes into the history of TB for the people that are interested. Okay, so Prof. Dan, I think this is the article you were talking about. Yeah. So this is an article done by Guy, apologies to him if I'm saying it wrong, but basically measures the concentration of 3 anti-TB drugs in spinal tuberculosis. And it was quite a cool study because they actually only gave treatment for 4.5 months. And importantly, it's to note is that every patient out of all 24 patients had surgery done at 4 weeks after starting TB treatment. And what they did is they took samples from the bone to check what the drug concentrations were of the various drugs. And The intensive phase was 2 months of RAZE, so that's our RIFA4, plus streptomycin, and then they went on to a continuation phase of 2.5 months with twice weekly rifampicin, isoniazid, and PZA. Okay, so we can now look at the bone penetration of the drug. So the way they divided it was dependent on if it was sclerotic bone or if it was non-sclerotic bone. Okay, so this is the serum concentration of the drugs, or the rifampicin, the isoniazid, and the PZA. And then this is in normal bony tissue, so in the ileum. And then subnormal bone was essentially the pathological bone, so the TB, the vertebra that's infected with TB. And as you can see, actually the drug concentrations between the ileum and the subnormal bone are actually relatively the same. But if you look at sclerotic wall of the vertebra, you can see drug penetration is really not good. So in this study, their feeling was that surgeries would be of utility for these patients to try and get rid of the sclerotic wall, to try and allow the drugs to penetrate. Okay, now let's go on to, so that's the drugs we've discussed, and then let's go on to duration of treatment. Unfortunately, there's not a lot of data surrounding that. We'll go into that now. But each society has their own recommendations. But if you follow the IDSA, Infectious Disease Society of America, or ATS, American Thoracic Society, and the CDC, they recommend 6 to 9 months. But experts favor 9 months because it's difficult to assess the response to treatment. And in patients that have orthopedic hardware, they suggest 12 months, but all of this is based on expert opinion. And then WHO says 9 months. And then you look at the NICE guidelines from the UK, and they say, well, if there's no CNS involvement, then you can consider 6 months of treatment. But if there's CNS involvement or coexisting HIV, then it's 9 months of treatment. Okay, and then let's go back to this Fox article and then look at the treatment of spinal tuberculosis. We've gone from 1965 to, if I'm not mistaken, this was 1993. So there's quite a lot of studies being done, and it's also in multiple different countries, but away here, South Africa for us. Problem is to try and read into this data is difficult, and that is because of the heterogeneity of the studies and comparison. So, for example, the Korean paper gave 3 SPH, so that's streptomycin, PAS, INH, and then PH, PAS, INH for 18 months. Whereas if you compare it to the Korean study over here, well, that's six months of isoniazid and rifampicin. And then if you look over here in Korea 1965, they put a jacket plaster of Paris as well. I think that I'd love to see photos of what that looked like. And then also some of them had, which we'll go into now, I'll go look a little bit more into these, but some of them had surgery involved with them, others just had chemotherapy given. And as you can see, the numbers are quite small. And I can understand it's not something that we see that commonly. I think we do see it here, and that's because we also get the referrals to the center over here. But it's not a really that common problem. And then let's look at the last 3 studies. So the ones done in Hong Kong, Madras, and Korea. And if you look at Hong Kong, they did 6HRS, so that's isoniazid, rifampicin, and streptomycin, with surgery versus 9 months of the same. And really the outcomes, the favorable outcomes were pretty much the same between the two. And then if you look at Madras, radical, so radical means surgical, and A and B is ambulatory, so that's ambulatory chemotherapy. So surgery, no surgery. And not too much of a difference between those arms, and they thought that there was not really much of significance whether you had chemotherapy for 9 or for 6. However, if you look at the Korean study over here, you can see there was quite a marked difference between 9PEH, so that's PAS, ethionamide, and INH, compared to 18 months of the same combination, where it was 90% over there versus 73. And I suspect that might be because there's no rifampicin or PZA given to those regimens. Okay, so now what's the way forward? I mean, these patients are incredibly difficult to monitor response. I mean, actually, most TB patients would just say, how are you feeling? Good, I'm doing better. Okay, weight's going up, night sweats have gone down, cough's got down. So that's quite easy to do, and following up on cultures if possible. But what about doing a FDG PET CT? And that basically looks at monitoring of uptake of glucose into the white cells when there's inflammation of TB. So that is a possibility. Let me show you a study which I think was done, if I'm not mistaken, on the other side of the Jesper River, and that's quite a recent study. They looked at 28 patients with TB spine, and they gave them all more than 9 months of treatment, and they included their population was both HIV positive, HIV negative, and they basically wanted to predict the metabolic activity of bone, and they looked at two components to this. So they looked at looking at the FDG PET CT, but they also looked at biomarkers. Okay, and I don't know what all of these biomarkers stand for. Some of them are cytokines, who knows? I think from a population point of view, rather difficult to do this in our setting unless it's in a research setting. But what was really, what was quite nice about it is that people are thinking ahead of trying to figure out what are the best ways to try and monitor treatment duration for them. And I think this might be something that we should be looking at in the near future. And then, as we were saying earlier, ESR is not a great test to be done in HIV populations. Okay, and then there was another study by Duraj, and they basically, same story, looked at this FDG PET CT, again, as a imaging biomarker and a prospective clinical observation study. And all 33 of their patients had biological, radiological findings in keeping of spinal TB. And their regimen, I find quite interesting. I'm not sure why they went like this, but anyway, they went for 4 months, then rifampicin, isoniazid, and ethambutol for 4 months, and then rifampicin, isoniazid for 4 months. So 12 months all in all. And they basically looked at this standardized uptake value. I called Stuart Moore this morning, and I was like, listen, man, I don't understand SUV. All I know is sports utility vehicle. I don't know what this is. So he says to me, Tari, don't even bother telling him about this. We even get copies of it. Okay. He said, but just essentially, what you can see into this is that the SUV is, in the beginning, will be high. It's the uptake. And then what you see is hopefully by the end of treatment, it goes to a much lower level. And basically what you need to take into account, there's a lot of other factors. I mean, he told me it's like 3 other SUVs that they look at, but by looking at the amount of metabolic activity, you can try and, with clinical interpretation and looking at other images as well, try to determine that yes, an FDG PET CT might be a good idea to follow up these patients. And it is something that hopefully will be done in the near future. Okay, so I think some stuff in conclusion is the treatment regimen. I mean, for our TB patients, we usually go Rifa-4, RNZE for 2 months, and then we go into continuation phase of rifampicin and isoniazid for another 4 months. And from what I've read from the data, especially from that Fox article, is that PZA ethambutol in the continuation phase, I'm not too sure how much added value it will give us. And then we really need more studies with regards to duration of treatment. There's just not enough in the literature. And then I think what's exciting for Kurdiski is that hopefully we'll be getting our own PET CT apparently next year. And maybe this will be something that we can actually look into prospectively and trying to have our own population, our own subset of patients with TB spine, where we can look in and see if we can follow them up and have our own data from here.
Can I ask a question?
Yes.
One slightly facetious one. The one point I remember from our last meeting is that I asked about bacteriostatic and bactericidal and said that's gone. Then your first slide is you're talking about sterilization. It's just confusing, but I don't expect your answer. Just the PET CT that Johan Davis says the spine surgeon Heidelberg that did the PET CT. I don't understand why PET CT would show active TB. I mean, it's FDG. It's meant to be for cancer metabolism. I understand that. So why would TB be indicated on a PET scan firstly. And then if you do, I mean, we seem to be quite confident we get rid of the sort of easy bacteria, but there's all intracellular lurkers that creep back when you're not looking. How's the PET-CT going to pick those up?
Yeah, thanks.
So you're getting a 21,000 rand investigation. Those are PET-CT.
This
is a private practice, 21,000 rand for PET-CT.
Sure. Is it cheaper than an MRI? Or is it more
No, it's
expensive?
more expensive than MRI. The whole body MRI is about the same with it, but a PET-CT is 21K.
Yeah, it's a lot. Yeah, thanks. So bacteriostatic bactericidal, we have moved away from using that, but I'm not sure in the TB literature if we have moved.
This is in bacteria, in normal bacteria. We're not talking about mycobacteria.
Yeah.
It's a different issue. Yeah. That was relating to into non-mycobacterial bacteria.
Okay.
And then with regards to thanks. So my understanding is that when you've got metabolically active bacilli in tissue, they consume glucose.
Not the bacilli, sorry.
Not the bacilli.
PET-CT has nothing to do with TB.
Yeah.
Okay, yes, I mean, it can be any infection, any inflammatory process. It detects inflammation, right? Or metabolically active tissues. And in the case of TB, that's inflammation.
Is it inflammation? Because I thought it was specifically for tumor metabolism.
No, it's been demonstrated in pulmonary TB very clearly that it's related to ongoing inflammation, and there's even a transcriptomic signature associated with it. So it's not going to tell you whether you've cured TB. It's actually not a great biomarker for that. People have looked at it very carefully, even for treatment short in pulmonary TB. That doesn't fit. The PREDICT trial hasn't reported yet, but I know the results of that. This isn't going to work. But I mean, I think it is a biomarker. It's part of like a tool set that could be used, and I think I agree with Terry. I think it should be studied in this indication because it's so difficult to understand.
In a particular study, they actually biopsied the patient, the first CT first, and they biopsied them, and about 30 of them were positive gene expert culture, so it wasn't that specific anyway.
No, it completely lacks specificity because I mean, it's not related to TB.
I mean, the only question I think is whether it's of any benefit in follow-up. But I don't think that, I mean, yeah.
So they use exclusively to check if patients who are on prolonged treatment have reactivated or
the key question for this tool is, does it predict relapse, right? I mean, can you say that at some threshold you can stop treatments, and at that threshold there's a low risk of relapse if you do stop treatments? And that would be the research question. I mean, what I meant is that in pulmonary TB, it doesn't seem to work for that.
Sorry. Just to ask a question whether we can get back to the issue of duration. Well, I think what Terry's shown, what we understand is that the 4 drugs, ethambutol and pyrazinamide in particular, like ethambutol in particular, is very useful, both very useful in the first couple of months. And there's also, as Terry mentioned, to reduce, to protect rifampicin in particular, so that in terms of resistance. So, the actual rationale for prolonging to 6 months, I don't think is there. Now, your question is, well, what about these difficult to get to bacteria and mycobacteria? And I think that's again comes back to Sean's question about, which is critical, which is the PK at the tissue site and trying to understand that. But my other question is, I mean, in South Africa, you guys are obviously world experts in spinal TB and in the numbers. Isn't it possible to do a 6 versus 9 months, or a 6 month of Rififlor versus 6 months of 2 months Rififlor, 4 months?
Yeah, look, I mean, you can do this study. I mean, you can argue about the ethics about it, but I'm sure you can get past that. But it's really, how do you detect the recurrence? What's the period of time you allow for the recurrence? And I mean, I've got this in my head, and I used to talk to every time I go overseas. I think of Graham Mankey's slides of the non-HIV patient that's got a 7% lifetime chance of pulmonary reactivation. And then with HIV, I think it's 7% per annum, So, and that's in pulmonary. The problem with the spine, it can start and this takes so long. It's not infrequent you go back to remove the instrumentation because it's bothering the patient. You find a little bit of pus there, even though the patient is totally asymptomatic, they seem to have controlled the disease. So that's a problem. How long? You'd have probably do a 10-year study to do
I appreciate what's being asked, but I mean, I'm not. The thing is that, as you mentioned, the bias that's inherent in your expert opinion because of the people you see coming back and not.
Absolutely. I mean,
That's what we need to probably do the power calculation, how many patients.
I mean,
Even for South Africa, you need such a big number of patients to take the difference.
It's India as well, remember?
So it will have to be multi-center, probably not just South Africa, and will need a massive amount of funding. But it's definitely we should do it. I mean,
The problem is, like, from a clinical point of view, we see the patients clinically getting better over that 9 months, but of course we don't understand, is it the drugs that are making a difference in that last 3 months, or is this the disease, the patient getting better? But there's no doubt that patients continue to improve over that whole cycle.
But again, there's an issue of, I mean, we're not comparing our apples and apples, we're comparing oranges and apples, but you're also aware now of a number of studies that show that despite ongoing signs of inflammation and infection markers, shorter periods of antibiotics actually have the same clinical outcome. I'm thinking now of intra-abdominal infection where you've got primary source control showing 4 days is absolutely no difference in clinical outcome to 10 days. And even when in 4 days they still had a raised CRP and temperature and a high white count.
Yeah.
So, we've also got to come back to the question of what we're asking those antimicrobials to do and how much, TB is an immunopathological disease, far better than why. But I mean, that's the issue. What are those antimicrobials doing and how long do you need to do?
And would you differentiate between your adjuvant therapy? Because in my mind, that's the other thing. So some patients will come to us, we don't operate. The only operation is diagnostic. So we're not debriding the tissue. There's a higher, we've shown that in the Chinese study that the sclerotic bone, so there's still sclerotic bone, as opposed to somebody you've aggressively debrided, your penetration is probably better because you haven't got that sac of pus anymore. So that's biofeeding anecdote. Well, I don't know, just intuitively that if you don't operate, you need a longer period of therapy. If I debride it and it's basically just going to pick up a few of those scattered cells, it needs less time,
You could say the same, you could turn it the other way around, say if you debride and really do that well, do you only need 2 months then?
Yeah.
Because I mean, that's the other study, again, is to look more deeply at surgery plus antimicrobials versus antimicrobials.
Yeah.
And I appreciate all the difficulties around surgery and the complication potential and time and effort and everything. But I mean, that's the other thing that probably we know that if you source control, your outcomes are generally better in any infection, doesn't matter if it's TB or whatever.
I want to ask the papers that you showed where they compared the resolution of the different drug regimes. How did they measure the resolution? Because that's one of the most difficult things is to know when is it gone? How did they measure the resolution in those papers?
I think it was based on clinically and radiologically.
That's the favorable outcome that you report today. Yeah.
But it also, I mean, surely we never eradicate TB, you just control. And I mean, there must be one mycobacterium left there somewhere. It's just that the person then suppresses that. Because I mean, a lot of TB is actually almost in my mind like an autoimmune disease. It stimulates the body to destroy itself. That's what we see in the spine. This granuloma is destroying everything. It's not really the TB, eating the vertebra away, so to speak. So, I mean, what's actually happening there? Why do some people reactivate and some don't reactivate?
The objective of TB treatment is what's called sterilizing cure, right? I mean, the assumption is that you are actually achieving sterilizing cure. And I'm talking about pulmonary TB because, most of the relapses, what you were mentioning was lifetime risk of TB.
Yeah.
But most of the relapses occur, at least in pulmonary TB, within a year. And the vast majority of those in 6 months. So if you were to design a trial, which I don't think is feasible in this condition, it's just, I think the numbers aren't big enough. I mean, you would follow up, I think, for 12 months, and I think that would give you a lot of confidence. But this would be answered, at least not answered, but strongly informed, I think, by a prospective study. You could just see your patients, do multiple, because they're going to do multiple interventions depending on the clinical situation, collect information, including PK, and try and find patient-level factors that can predict relapse. So, just get a cohort of people together and follow them for a long time. And I think that will inform this deeply. The trial, I mean, the relapse rate is probably going to be 10%. It's not going to be that high, actually, if you give people 9 months or 6 months of treatment, I don't think. And to show non-equivalent, I mean, to show non-inferiority between two approaches. You don't need 1,000 patients.
Yeah, but look, I'm not a statistician,
Yeah.
I'm not a trial expert either, but I mean, the whole issue of trials as we move forward and the potential for using different methodology, to perhaps answer these difficult questions, that would need to be talked about.
Maybe DDPCR can be a biomarker.
DDPCR. I wonder, I mean, there are quite a few people joining the meeting from afar, and some, Eunice and others have a lot of experience in treating TB. I just wondered whether anybody else also had a comment. I mean, Eunice, I don't know if you've, if you could give us some idea of how you go about this question in KZN, what the approach is.
Thanks, Mark. Yeah, actually, the orthopods do exactly what your orthopods in Cape Town do. They treat for RIFA for 6 to 9 months, and my feelings are aligned with the ID department in Cape Town. That really 6 months of treatment should be adequate, with 2 months of intensive phase and 4 months of continuation phase. And the fact that this is a paucibacillary disease, my feeling is that we probably have eliminated the organism. And all we're looking at is the resolution of the inflammation, and we want to be sure that there isn't a recurrence. I had a question for the presentation about the German patient. I was wondering, when the sample was taken at surgery, was it sent for culture, and did they find any TB in the culture?
Yes, it was positive both times.
Okay, so that means that the decision to prolong TB treatment was actually a good idea. So that might be an instructive case, that despite prolonged treatment, there was still positive culture, which means that I need to rethink about how I'm seeing this disease.
Yeah, see, but the physician involved, they're diagnosed as a rapid rifampicin metabolizer. They felt for the dose she was on, her blood levels were too low, and so they added more rifampicin. Yeah, you're shaking your head.
Yeah, but then again, we assume that the dose we use in all patients should be equal, and we don't individualize treatment. So I might need to rethink about the duration of treatment in spinal TB, because I belong to the group the way I believe that whatever we do for pulmonary TB should be adequate for spinal TB, but clearly that might not be the case. So the study that Mark suggested would actually be an excellent study. I know it's a bit of a difficult study to do, and how do you decide if somebody has got ongoing TB once you have stopped treatment is challenging, but I think it's still worthwhile doing. Thank you for allowing me to comment.
I wanted to ask about that case, because I recently had a case in private. We don't use it often, but the oral anti-thrombotic agents that's commonly used in pillows like Xarelto, apparently there's a big drug interaction with rifampicin, and it's contraindicated to use it together. So, and it's commonly used in orthopedic patients in private instead of oral agents. So is that something to take into consideration?
Yeah, there's an interaction between rifampicin and rivaroxaban. I think that's what you're talking about.
Yes.
Right? It can probably be overcome by doubling the dose, but you can't monitor rivaroxaban. So just change the patient to another rifamycin for beauty.
So when you guys propose, do you think that there's enough evidence that we should just go on to standard pulmonary TB, 2 months of intensive phase, 4 months of continuation, or what's the
Yeah, I mean, look, I'm on that side of the fence. Yeah, I think so. But I mean, I think Sean's point about prospectively monitoring and following up, I think the question is, how long do you do it? But the other issue is that people do get TB again. It's not just the reactivation issue, it's potentially a reinfection issue. Of course, that's pulmonary TB is probably more likely to come into play there, but if it disseminates and there's an area, of potentially that is at risk, like a previously infected area in the spine, who knows? I don't know the answer to that. But I have gone much more towards everybody getting 2 months and 4 months, a 6-month course. Because remember, it's not just orthopedic, it's, you know, the abdominal TB, CNS TB, a lot of other TB is treated for longer, based on often on historic issues.
I think more people than we think are de-escalated anyway, because you don't follow everyone up and people go to the clinic. We think they're getting numbed before, but a lot of them at the clinic are going over to the maintenance phase anyway.
Sure. But you don't know what happens to them, they don't all die.
If you look back, I mean, if you've got some registry of this, I mean, I'm sure you guys have recorded all of your spinal TB cases, just like, you know, an MMed student, to go and just track the outcomes of all of them, how much TB treatment they got, so just describe that. I mean, you might find that, you know, most of them got 6 months and did well.
Yeah.
I mean, my view on this question.
Do the clinic records to see what they
Yeah,
actually
I mean, you know, it's not perfect.
Sounds more like a PhD.
But I mean, my view on this is that I think I definitely think that pyrazinamide and inflammasome should be stopped after 2 months. I don't think it adds any additional activity or benefits. And then I would suggest that the duration is 6 to 12 months based on clinical response. And, you know, patients who you feel using whatever metrics you use are not responding well, just prolong.
But still, just 2 months of propofol.
Yes, still 2 months.
But that's still the question, Sean. What defines that?
No, but that's it. We don't know, right? I mean, we don't know, but I mean, these guys know in their hearts.
We've seen evidence of it. We know that they're carrying. but that's the crux of it, isn't it? If our colleagues say they're not doing well, is that because they got infection, or is it because of the inflammatory issue? And, you know, each one is different. What was their starting point versus, you know, I mean, it's really tough. But my feeling is that, you know, this is is one of the great immunopathological diseases. You got what happens with the bug, what happens with the immune system, and the bug is the one you want to get rid of relatively quickly, which you're going to do within 6 months of treatment. I don't believe that it's going to increase recurrence of the disease.
We do this for CNS TB and TB adenitis all the time, right? I mean, we make a judgment and think, okay, well, let's extend the treatment. And that's what I'm suggesting.
Yeah, TB adenitis usually, I mean, I've not used more than 6 months for
These
TB
are hard
adenitis for years.
Yeah.
CNS TB is much more difficult, particularly because it seems with tuberculosis, for example, you know, things wax and wane.
Yeah.
And each individual patient is actually individual, you know, because so some you'll have space occupying lesions and you'll treat, and after 6 months, scans are absolutely normal, absolutely fine. You may come back, you know, and within that also you may have patients who they'll go at 2 months and then at 6 months they'll be back and go, even though they're on treatment, even though their drug levels are fine. So it really is a complex issue.
Yeah.
But I agree with Sean, definitely 2 months of 4 drugs, and then the duration, I would go for 6 months.
I just want to add something from the pediatric point of view. So I know I'm one of the people working at the stuff in Crystal. And well, firstly, our patient cohort is slightly different to the TB spine cohort in the sense that we have very little HIV co-infection. In fact, in the most recent write-up, I had 0. So ESR is used as reliable in our setting, and just anecdotally, after 3 months of TB treatment, ESR is usually below 10. So that's one point. And then the other thing I wanted to say is in terms of evaluating the efficacy of 6 months versus 9 months and de-escalation, we already have data for 9 months. So we don't need to do a comparative trial. So for instance, if we agree with you, then I must say the evidence, what little evidence there is a little bit convincing. You're telling me that pyrazinamide and the stops working after 2 months, it stops adding benefit after 2 months, and then why on earth are we going on with it? And that seems to be more scientific in our anecdotal evidence of carrying on with it forever. So if we just make the agreement or agree between myself and Stuart that, okay, cool, let's try this, see if it works, and then you can compare it to our existing data. And I mean, so we already have control, so we just need to
no doubt the place to do it is here, you know, in Sterilization Center, and it's like to say we might not need a prospective RCT to get a feeling good answer.
We can do a historical cohort, this is a prospective cohort, and it's just a couple of minutes, it just makes it actually.
Sipo's got his hand up.
Sipo, you're going to give a comment?
Yeah, no, thanks. And thanks very much. Look, it's very interesting discussion and topic. And mine, I'm more with the orthopedic surgeons on this issue. Just because, look, I think it's biased. One, because these are the patients I tend to see and we probably co-manage with the orthopedic surgeons. I think the issue really is that it's the site of disease. So these individuals have spinal disease. You've only got one opportunity to really get it right. And it's incredibly difficult to treat these patients because one of the things you're trying to do is return them back to functionality. I mean, I think the reduction to 9 months is good. And I think the experience is that seems to work very well. The issue about intensive phase of 2 months or even extending that to say 4 months of intensive phase and then 3 months of continuation phase is probably something that also needs to be discussed and looked at. And I think you know, it is very challenging because, you know, spinal TB and tuberculosis are conditions that are heavily neglected. There isn't enough data to tell us exactly what to do. And often what we're left with is people's experience on the ground. And there are some patients who probably 2 months of intensive phase is fair. And I think what probably is fair is those who've had surgery in terms of removal of most of the abscesses, probably you could do the 2 months intensive phase and then you know, the standard 2 months intensive phase and continuation phase of 4 months. But those where you've just biopsied and left a lot of sort of granulomatous tissue behind, I think needs real thinking about how you manage those patients, given that if you get it wrong, you know, you're going to be left with somebody who can't be functional again. That's just my 2 cents.
Yeah.